And Dr. Banales, I will make your co-host. You're more than welcome to record as well. Okay, so we'll get started. So good morning, good afternoon, good evening to each and every single one of you. We are very, very excited to have you today at the Massachusetts General Hospital Global Gastroenterology Monthly Educational Series. So October is Liver Cancer Awareness Month. So it is truly, truly an honor for us to have Dr. Jesus Banales with us today. He will be focused on the topic of cholangiocarcinoma. The format of the session today is he'll present, and then we'll have an opportunity for questions at the end. We're going to be very respectful of time, and we'll conclude as appropriately defined at 1 hour. So any other questions that come after that, sorry, we won't be able to answer them. But we could probably share with him and see if his time allows outside of the forum. So I will briefly introduce Dr. Banales, and then we'll get started. So Dr. Jesus Banales is the chair of the Liver Disease Group in Sebastian, Spain. He's a full professor of molecular biology and genetics at the University of Navarra, Pamplona, Spain, and an associate professor of medicine sciences at Mayo Clinic in the US and University of Área Andina, Colombia. His group is studying the molecular mechanisms involved in cholangiocarcinoma and the development of novel diagnostic and therapeutic strategies. Professor Banales has authored more than 250 scientific publications, and he has led over 80 national and international competitive research projects. He is the editorial board member of Hepatology, Journal of Hepatology Associate Editor, Nature Reviews Gastroenterology and Hepatology, and Liver Transplantation. He has been recognized with international research awards like the EASL Emerging Leader Award in 2018, UEG Rising Star Award in 2018, and the PSC Partners Douglas Carlson Research Award in 2024. So it's truly an honor to have a world-renowned presenter with us today. And I was saying just before we started, I'd sent an email asking and inviting him. He said yes immediately. And then we went back and forth in terms of like finding a time. And inside I was like, please, I hope this works. And I just wanted to thank him for his patience because we had a lot of emails to make this happen. And on a personal note, I'm just very, very grateful that, we could make it happen. Super excited for your talk today and look forward to learning from you. I will share the first few slides just for the CME purposes. And then I'll hand over to Dr. Banales, who will go over the rest of the slides. And he'll have these exact slides. So this is just a reminder to the attendees that the program today is CME approved by Massachusetts General Hospital. As mentioned, the objectives are classify cholangiocarcinoma and will focus on the global epidemiology and risk factors of cholangiocarcinoma. So this is the form. Please feel free to scan that information. This will be available for you as well online. So there you go. That's information necessary for CME. And now I will hand this over to Dr. Banales. Once again, big thank you for your time. Truly appreciate your dedication. Over to you.
Well, thank you very much, Ragwi, for your kind introduction, for your invitation. It's a really great honor to be here. I want to highlight your tremendous effort for international education on liver diseases. I have the opportunity to meet you a couple of times during different international meetings, and I'm very impressed about the amazing things that you have done. So it's a really honor and pleasure to be here. And hello, everyone who is in the audience, and thank you for attending this webinar. So the purpose of this webinar is to focus attention on cholangiocarcinoma, particularly on epidemiology, risk factors, and clinical outcomes. So I have organized this presentation, first of all, with a general introduction on the disease, followed by information on the natural course, and then treatment aspects and personalized targeted therapies. And in the last slides, I will provide some insights on next clinical challenges. So cholangiocarcinoma includes a heterogeneous group of malignancies characterized by the expression of markers of biliary differentiation. It is the second most common primary liver cancer after hepatocellular carcinoma, and its incidence is increasing worldwide, being particularly high in certain Eastern countries such as Thailand, China, or South Korea, with more than 6 cases per 100,000 inhabitants. Traditionally, it was considered that cholangiocarcinoma represented between 10 and 15% of all total liver tumors, 3% of gastrointestinal malignancies, and to be responsible in about 2% of all cancer-related deaths. However, this data seems to be clearly underestimated due to common errors in diagnosis, coding, and data retrieval. This slide shows the annual mortality rate associated to cholangiocarcinoma within the period 2000 and 2014, according to data from the World Health Organization and the Pan American Health Organization, including 32 countries from Europe, America, Asia, and Oceania. As you can see in the picture, the annual mortality rate associated to cholangiocarcinoma increased within this period in all the countries evaluated. Here you can see the US, but you can see a significant number of countries. And this increase was particularly high in certain eastern countries such as Japan or Hong Kong. Among the potential causes of this increased annual mortality rate associated to cholangiocarcinoma could be an increased knowledge and awareness on this disease during the last years, a better diagnosis, but also an increase in incidence. In this regard, it is important to highlight that most of the patients have an unclear etiology or an unknown etiology at diagnosis. However, it's important to highlight that there are several factors that highly increase the risk of cholangiocarcinoma development, like the presence of choledochal cysts, gallstones, cirrhosis, biliary diseases such as Caroli or primary sclerosing cholangitis, viruses like hepatitis B or C virus, and certain liver flukes, like Orbistorchid viverrini and Clonorchis sinensis, which are two parasites endemics from certain regions of Southeast Asia and responsible, at least in part, of the high incidence of this cancer in those regions. On the other hand, there are other factors that induce moderate risk but that are highly prevalent, like alcoholic liver disease, type 2 diabetes, tobacco use, and muscle D. Age is another risk factor. The median age at diagnosis, according to data from the International Cholangiocarcinoma Registry, was 66 years, and 75% of the patients presented more than 58 years at diagnosis. And last but not least, there is a proportion of cases, around 5% of patients, who present germline mutations in different tumor suppressor genes that increase the risk for the development of different types of cancers, including cholangiocarcinoma. Are there genetic susceptibility rather than mutations for the development of cholangiocarcinoma, for example, in terms of SNPs? This is a question that Professor Luis Roberts is trying to address in an international collaborative study. He and many of us have been working for years trying to establish potential links between SNPs and cancer risk. More than 4,000 cholangiocarcinoma cases and more than 1,000 samples from gallbladder cancer were genotyped at the National Cancer Institute. Some SNP variants were identified with significant association with cancer risk, and these data, still unpublished, are currently under validation phase, and I hope will be published very soon. Most of the samples included here in the discovery were from Europe and the States, but the validation phase is including samples worldwide from Asia, Latin America, and Africa. Are there any factors that could prevent the development of cholangiocarcinoma? Well, this is a systematic review and meta-analysis including 9 studies, and in total more than 12,000 cholangiocarcinoma cases and more than 92 million controls. The results showed that individuals with chronic aspirin consumption, with low or moderate dose, were associated with a lower risk of presenting cholangiocarcinoma, both intrahepatic and extrahepatic cholangiocarcinoma. Aspirin was also investigated after the diagnosis of cholangiocarcinoma, and this publication published in JAMA Oncology in 2019 showed that the aspirin use after biliary tract cancer diagnosis was associated with a lower risk of death in patients with advanced cholangiocarcinoma compared with individuals non-users of aspirin. These provocative data still are preliminary, retrospective, and the paper still lack important information like the cancer stage and the chemotherapeutic regimes received in both arms. So I think this must be interpreted with caution, but both studies indicate that aspirin could potentially have a potential role. In this regard, there is a prospective clinical trial started last year in the UK in order to evaluate the effect of aspirin on reducing cancer and improving outcomes in patients with primary sclerosing cholangitis. This is a study that was initiated again around 2 years ago, and is planning to include a high number of patients with PSC and evaluate again the cancer development and all the clinical outcomes. So we are very excited to see the results on this. On the other hand, the use of statins was investigated on cholangiocarcinoma risk. This is a case control study including more than 3,000 cholangiocarcinomas and controls. And as you can see, the statin consumption was associated with a lower risk of presenting or developing cholangiocarcinoma. This association was observed for different statins types. And this data from Taiwan were validated in a recent UK study, also with more or less the same number of cholangiocarcinomas and controls, concluding with the same information that the consumption of statins was associated with a lower risk of cholangiocarcinoma between 12 and 20%, and it was found more pronounced among patients, long-term users of statins. Based on this data, a Swedish population study was carried out evaluating 5.7 million people without personal history of cholangiocarcinoma. From this total number of individuals, 2,160 individuals developed biliary tract cancer. The authors didn't find any association between low dose of aspirins and the cholangiocarcinoma risk, but they confirmed that the use of statins with or without low dose of aspirin was associated with lower risk of cholangiocarcinoma, both intrahepatic and extrahepatic. This data strongly highlight that the fatty liver probably is playing a very important role in the increase of cholangiocarcinoma incidence worldwide, and the use of statins could prevent the cancer-associated development in this liver condition. But we need, again, prospective data. Regarding the natural course of the disease, due to the potential differences in etiology, pathogenesis, risk factors, incidence, and prognosis, the WHO has recently approved a new classification of cholangiocarcinomas in 3 subtypes: intrahepatic, perihilar, which are the most frequent one, and distal cholangiocarcinomas. And until very recently, there were not international data on the natural course of the disease, evaluating a large number of cholangiocarcinoma cases and also comparing the new coded 3 cholangiocarcinomas, intrahepatic, perihilar, and distal, trying to see the similarities and differences in the natural course. So that's why we investigated the natural cause of cholangiocarcinoma and its subtypes in hospitals from the European Network for the Study of Cholangiocarcinoma, ENSCA. In this study, we included the ENSCA registry, which is a multi-center observational study, and we included cholangiocarcinoma cases with a confirmed diagnosis by histology or highly suspicious by cytology. We include cases diagnosed between 2010 and 2019, and from a total of around 2,000 cases, more than 2,000 were included for the epidemiological analysis and almost 2,000 for the survival analysis. We evaluated all cholangiocarcinoma cases together, and also we compare the 3 cholangiocarcinoma subtypes. In total, 26 referent health centers from 11 European countries participated in this study. So the diagnosis of cholangiocarcinoma comprised a sequential combination of imaging techniques, the analysis of non-specific tumor markers in serum, such as CA19-9 and CEA. A final histological confirmation is necessary to confirm again the presence of cholangiocarcinoma. The accuracy of these 2 biomarkers was on debate for many years. Because there were data that was not really sensitive and specific in different small studies. In this study, we found that, as you can see here, the levels of both biomarkers, the median value, is below the upper limit of normality of both biomarkers for patients with local disease. So you can see we pull here all cholangiocarcinoma with local disease, and then we stratify cases for intrahepatic, perihilar, and distal. And you can see that the levels are very low and below the upper limit of normality when the disease is local. However, when the patients presented an elevation of these biomarkers diagnosis, this was associated with a higher risk of presenting locally advanced disease, but particularly metastatic disease. In this regard, elevation of both biomarkers at diagnosis was associated with a higher risk of presenting metastasis compared with the single elevation of any of these 2 biomarkers. So the elevation of these biomarkers is associated with a staging, with a more disseminated disease. However, it's important to take into account that, for example, CA19-9, the Lewis antigen A, is not expressed in about 10% of the population due to a deficiency in the FUT3 fucosyltransferase enzyme necessary to generate this antigen. Regarding clinical management and survival, as you can see here, patients under best supportive care show a dismal prognosis with a median overall survival of just 4 months that increased up to 10.6 months in patients receiving active palliative treatment, mainly the combination of gemcitabine and cisplatin. For patients undergoing surgery, if the surgery is complete, R0, the median overall survival observed was 45 months. That decreased up to 25 months in patients with R1 tumor resection, so with microscopic margins of disease. Then we identify several demographic and clinical variables associated with prognosis in a univariate analysis. Interestingly, the multivariate analysis show up 3 variables independently associated with prognosis, which are the ECOG performance status at diagnosis, the disease stage, and also the levels of CA19-9. Next, we evaluated the success of the surgery and the presence or absence of lymph node invasions in terms of the overall survival of the patients. And as expected, patients with complete tumor resection and absence of lymph node invasion were those with the highest median overall survival, 52 months, compared with the other groups. And finally, we evaluated the clinical management and survival of patients comparing the 3 cholangiocarcinoma subtypes. We didn't identify differences in overall survival in patients undergoing R0 or R1 tumor resection, or even in patients under active palliative treatment between the 3 cholangiocarcinoma subtypes. However, we found that individuals with intrahepatic cholangiocarcinoma under best supportive care show worse overall survival compared to patients with perihilar or distal tumors. This is potentially associated to the fact that a proportion of patients with intrahepatic cholangiocarcinoma have associated chronic liver disease and could be behind this dismal prognosis. We carried out recently another natural course study, in this case in Latin America. This is a publication from a few months ago. We observed more or less the same results. And here what we did was to evaluate also potential disparities in terms of presentation, management, and outcome based on the ethnicity of the individuals. And we compare individuals Caucasian, African, and Hispanic. Interestingly, we found that the Caucasian individuals were associated with the best outcomes and overall survival. African individuals were associated with a presentation of the disease with a more advanced stage. And also we found that Hispanic individuals receive less frequently chemotherapy when the disease is advanced compared to Caucasian. So we provide some potential associated aspects that could be behind of this worse prognosis of patients from African or Hispanic ancestry, particularly socioeconomic aspects and educational information on the benefit of chemotherapy and also on the awareness of early symptoms. Regarding the treatments, the treatment landscape for patients with advanced disease, the systemic therapies have significantly expanded during the last years. So in 2010, the ABC02 trial evaluating the therapeutic benefit of Gemcis was investigated with positive results. Since then, triple combinations with Gemcis and other chemotherapeutic agents were investigated, or other molecules with no additive benefit were observed. But since 2019, the landscape in first-line and second-line chemotherapy and immunotherapies has significantly changed with positive results. I will show in the next slides the most important studies. Regarding chemoadjuvant therapy post-surgery, this is the BILCA phase 3 clinical trial, where capecitabine was investigated in a group of individuals compared with an observational group. As you can see here, individuals under capecitabine show an increased disease-free survival in both in the intention to treat and in the per protocol analysis compared to the observational group. You can see here the median disease-free survival from 17 to 24 months in the capecitabine group. In terms of overall survival, they also identify that individuals under capecitabine show an almost significant benefit in overall survival in the intention to treat analysis and significant in the per protocol analysis. from 36 to 52 months in the median overall survival. Based on these results, partially positive, capecitabine is currently considered the standard adjuvant treatment for all cholangiocarcinoma subtypes based on international guidelines. For patients with advanced disease and in terms of systemic therapy, this is the ABC02 trial that I mentioned before, a phase 3 trial published in 2010 in New England Journal of Medicine, where the combination of gemcitabine and cisplatin shows superior progression-free survival and overall survival compared to the control group receiving gemcitabine. The benefit was modest but significant, with an increase in around 3 months in median progression-free survival and overall survival. So this became the standard of care in first line for these patients since 2010. At the molecular level, as you know, gemcitabine is a nucleoside analog that is incorporated by the cells and in a high concentration by tumor cells. It follows a couple of molecular changes, forming a nucleotide analog, which incorporates into the DNA and induces apoptosis of the cells. On the other hand, cisplatin is an alkylating metal that binds to the carbon 7 of two guanines. It has B electrophilic capacity, so it binds to two close guanines, mostly in the same strand of the DNA. This causes intra-strand crosslinks and intra-strand breaks. This usually induces death in cancer cells, but the cells over the cycles of chemotherapy usually adapt themselves, stimulating mechanisms of repair of this damage, becoming resistant. The number of interstrand crosslink and interstrand breaks, which are more challenging for the tumor cells to repair, are less abundant, around 5%. So in general, the tumor mutational burden of cholangiocarcinoma is low. Cholangiocarcinoma tumors usually present less than 10 mutations per megabase, per million of bases. So in general, they respond bad to chemotherapy, to checkpoint inhibitors, with the exception of patients with microsatellite instability. With the idea to promote the immune response to the tumor, these two clinical trials were recently developed and published, the TOPAZ-1 and the Keynote 966, which combine immunotherapy, durvalumab or pembrolizumab, plus Gemcis compared to a placebo plus Gemcis group. As you can see, both trials show quite similar results, with a modest but significant benefit in terms of overall survival compared to the control group. And based on these results, this new triple combination is the standard of care in first line for patients with advanced cholangiocarcinoma, for all kinds of cholangiocarcinomas. With the idea to increase the number of interstrand crosslinks and breaks, we designed, synthesized, and investigated in experimental models a new family of chemotherapeutic agents called Aurkene. Aurkene, I show you here the structure of two of these molecules, Aurkene 16 and Aurkene 18. This chemotherapeutic agent has a platinum molecule plus an organic structure. The idea of this structure is to promote a polyelectrophilic capacity. So in comparison to all the current cisplatin molecules that has B electrophilic capacity, so capacity to bind to two guanines, this structure theoretically allows to interact with more guanines, promoting a higher frequency of interstrand crosslinks and break, which are much more challenging for cancer cells to repair. So we carry out computational analysis and found that they show that these molecules could indeed potentially bind to guanines in both strands and induce a significant rotation and break in the DNA. So we investigated these new compounds in experimental models of cholangiocarcinoma. We found that these molecules are incorporated not only by CTR1, which is a transporter of cisplatin in general. Also, these molecules are able to be transported by organic cation transporters, which are highly overexpressed in cholangiocarcinoma cells. And we demonstrated that these molecules, in contrast to cisplatin and the other platinum compounds, induce a high frequency of double-strand DNA breaks, resulting in cell death, and not only in cholangiocarcinoma cells naive to the treatment, also in cholangiocarcinoma cells resistant to cisplatin. We found that this effect was highly selective for cancer cells, and we didn't find any effect in normal cholangiocytes. We investigated the therapeutic value of these chemotherapeutic agents in vivo, and we inject cholangiocarcinoma human cells subcutaneously in immunodeficient mice. We treated animals with Arkenes 16, and as you can see, the tumor growth was significantly lower compared to the group of animals receiving vehicle or cisplatin. Same experiments were conducted, but in this case, injecting cholangiocarcinoma cells resistant to cisplatin. And as you can see here, animals receiving Arkenes 16 or Arkenes 18 here in red and blue show a significant reduced tumor growth compared to animals harboring the tumors and being exposed to cisplatin or vehicle. Finally, we include an orthotopic model, an immunocompetent animal model where we develop cholangiocarcinomas in the liver. And as you can see, animals treated with Arkenes 16 show a reduced tumor growth in the liver compared to the control group. When we evaluated the tumor features histologically, we found a significantly higher infiltration of CD4 and CD8 lymphocytes in the tumors of animals treated with Arkenes 16, suggesting that a potential combination of these chemotherapeutic agents with immunocheckpoint inhibitors could have potential additive or synergic value. In this regard, we have just received the good news from the European Commission that they have funded a new study in which we want to evaluate the therapeutic benefit of the combination of these Arkenes compounds plus immunocheckpoint inhibitors using sophisticated experimental models, both in vitro and in vivo, as well as experimental models derived from patients like precision cut tumor slices and cholangiocarcinoma on chip. On the other hand, it's important to highlight that cholangiocarcinomas are highly heterogeneous at the mutational level, and this is a limitation in order to find common and effective therapies for all cases, but this is a unique opportunity for personalized and targeted therapies. In this regard, around 40% of genetic alterations in cholangiocarcinoma tumors are potentially actionable, are potentially inhibited with selected inhibitors. And different compounds have already approved in second line in patients who progress to the triple combination in first line. These drugs are selectively directed to certain oncogenes. I will, in the next slide, present some of these data. Some of these genetic alterations are frequently found in intrahepatic cholangiocarcinomas, like mutations in IDH1 or FGFR receptor 2 fusions, whereas mutations in KRAS or HER2 amplifications are more frequently found in perihilar and distal tumors. In this slide, I show you a number of phase 2 clinical trials in second line, specifically directed for patients with FGFR receptor 2 fusions, IDH1 mutations, BRAF mutations, NTRK fusions, and HER2 amplification or mutations. As you can see, a significant proportion of the patients with these targeted therapies show a stabilization of the disease over a significant period of time, a partial response, or even a number of cases develop a complete response. Based on these positive results, these targeted therapies have already been approved in second line in patients with cholangiocarcinoma. This is an approval both by FDA and AMA. At the molecular level, I will explain a little bit more on these alterations. These are the FGFR receptor 2 fusions, the fibroblast growth factor receptor 2 fusions. They are commonly found in intrahepatic cholangiocarcinomas in around 10–15% of the cases. Usually, they are a fusion generated at the DNA level. So there is a translocation of a partner gene. There are different partner genes, but big one is a common one who is translocated into the carboxy terminal region of the receptor at the DNA level. So most of the translocations and fusions are present at the DNA level. However, there are a proportion of fusions that are also generated at the RNA level. These fusions cause the dimerization and activation of the ligand independently of the dimerization and activation of the receptor independently of the presence of the ligand. This dimerization and activation of the receptor promote the phosphorylation and activation of a molecular cascade of proteins that activates two important signaling pathways involved in cholangiocarcinogenesis, the KRAS and the AKT pathways. The way to identify this genetic alteration is by analyzing the tumor by next-generation sequencing. There are two inhibitors already approved, pemigatinib and futibatinib. These are not selective inhibitors for FGFR receptor 2 fusions because they also are able to inhibit other FGFR receptor isoforms. And now there are clinical studies investigating more selective FGFR receptor 2 fusions that in the next future, I am pretty sure that we will have the results. On the other hand, a proportion of the cases present HER2 amplifications or overexpressions. As you know, HER2 is a transmembrane receptor tyrosine kinase that it needs to be dimerized, needs a dimerization to activate again these two key signaling pathways, the KRAS and the AKT signaling pathways. Most of these overexpression and amplifications occur in perihilar and distal tumors, and this overexpression promotes the dimerization of the receptor, forming homodimers or heterodimers with other receptors like EGF receptor. The way to identify this amplification is by immunohistochemistry or next-generation sequencing. Different monoclonal antibodies have been investigated for HER2 amplification or overexpression with good results. One is the combination of trastuzumab and pertuzumab. Another is the use of trastuzumab with a conjugation with deruxtecan, which is a chemotherapy. And finally, a bispecific antibody, zanidatamab, has been recently approved for this kind of genetic alteration in patients with cholangiocarcinoma. On the other hand, mutations in KRAS are quite common in cholangiocarcinoma and in other epithelial cancers. These mutations are associated with poor prognosis and usually are present in tumors arising from the large bile ducts, intra or extrahepatic. Historically, KRAS was very challenging to be targeted, and for many years, scientists tried to develop inhibitors for KRAS and been unsuccessful. But during the last year, selective inhibitors has been developed for certain mutations within KRAS. So KRAS in G12C, which is present in the exon 12 of the gene, is present in around 8% of cholangiocarcinomas. Two selective inhibitors have been developed, sotorasib and adagrasib, and they have shown a significant benefit in patients harboring these genetic alterations. On the other hand, mutations in BRAF are present in about 5% of cholangiocarcinomas, and it has been shown that the combination of a selective inhibitor, dabrafenib plus trametinib, which is an inhibitor of MEK, both compounds are able to inhibit the progression of cholangiocarcinomas harboring this genetic alteration. So this genetic mutation, FGFR receptor 2 fusion, HER2 amplifications, KRAS mutation, or BRAF, are associated with a highly proliferative phenotype of cholangiocarcinomas. There are other mutations that affect metabolic enzymes, and one is the mutation in the isocitrate dehydrogenase, IDH. This is an enzyme that has different isoforms. Isoform 1, IDH1, is present in the cytosol and lysosomes, and IDH2 in the mitochondria. These enzymes promote the conversion of isocitrate in alpha-ketoglutarate. Alpha-ketoglutarate in the cytoplasm usually migrate to the nucleus and activate different enzymes that stimulate the demethylation of the DNA, promoting the expression of multiple genes. Also, alpha-ketoglutarate is a molecule needed for the production of glutamate or glutamine, so amino acids, and also to control the redox balance of the cell. Mutations in IDH are more frequent than mutations in IDH2, and these usually occur in intrahepatic cholangiocarcinomas. These mutations are found in heterozygosis, and these cause heterodimers, an heterodimer of the protein with a wild type and a mutated protein. So this new heterodimer gain a new activity, which is the generation of D2-hydroxyglutarate, which is an oncometabolite, and it is generated from the alpha-ketoglutarate. The 2-hydroxyglutarate, these oncometabolites, inhibit the enzymes that demethylate the DNA and the histone. So as a result, as a result of the effect of this oncometabolite, there is a hypermethylation of promoters of different tumor suppressor genes and also genes involved in the differentiation of the cell. As a result, the tumors are highly undifferentiated and they respond significantly well to energetic stress and also hypoxia. It has been shown that this oncometabolite is secreted by cancer cells, creating an immunocold microenvironment. Actually, this oncometabolite is believed to inhibit the CD8 T lymphocyte effect, so the cytotoxic effect of these cells. A selective inhibitor has already been developed, ivosidenib, with positive results in patients harboring IDH1 mutation. And it is believed that the combination of this inhibitor plus immunocheckpoint inhibitors could have potential synergic effect in these kind of patients. For patients do not harboring actionable alteration, this clinical trial, the ABC06 phase 3 clinical trial, was developed, evaluating the potential benefit of FOLFOX compared with an observational group, everything, of course, in second line. As you can see, individuals receiving FOLFOX show a very modest but significant increase in the median overall survival compared to the observational group, becoming the second line treatment for patients without harboring genetic alterations which are actionable, so for patients with no actionable alterations. Finally, liver transplantation was traditionally contraindicated for patients with cholangiocarcinoma. However, there are significant retrospective data indicating that liver transplantation could be a potential good tool, good strategy for patients very selected cholangiocarcinoma cases. This is a study published in 2016. It's an international retrospective study in patients with liver transplantation for descompensated cirrhosis. They found that a number of these patients presented in the explant cancer, and some of them presented cholangiocarcinoma. They found that individuals with low tumor lesions, less than 2 centimeters, show higher overall survival and less recurrence compared to individuals with a more advanced intrahepatic cholangiocarcinoma, indicating that patients with cirrhosis and intrahepatic cholangiocarcinoma in early stages could be good candidates for liver transplantation. Regarding perihilar cholangiocarcinoma, this is another study from the Mayo Clinic. Also, they include 237 perihilar cholangiocarcinomas irresectable with tumor lesions similar or smaller than 3 centimeters. And all the patients receive neoadjuvant treatment with chemoradiation. They split the results according to the etiology: patient with primary sclerosing cholangitis or with a cholangiocarcinoma de novo. As you can see, the 10-year overall survival was significantly good, particularly better for patients with PSC, and the chances of recurrence were about 30%, better again for patients with PSC. So nowadays, there are prospective clinical trials trying to evaluate the therapeutic benefit of liver transplantation in this context. And as a final objective, so I try to provide some insights on next clinical challenges. Nowadays, there are a deep investigation on different immunotherapy strategies. For example, there are ongoing studies evaluating novel B-specific antibodies as well as novel immunocheckpoint inhibitors. There are phase 1 clinical trials evaluating the effect of adoptive T-cell therapy, so CAR T-cells, with the idea to identify tumor neoantigens that are expressed by cancer cells and try to generate T lymphocytes directed to identify these genetic alterations. On the other hand, there are other trials evaluating combination of immunocheckpoint inhibitors with chemotherapy, radiation, or tumor ablation. And finally, the therapeutic vaccines, which basically means the identification of the tumor neoantigens, the presentation of these neoantigens to dendritic cells from the patient, and then injection of these dendritic cells into the patients for the promotion of the immune response against the cancer. Last but not least, I think that the future needs more international collaboration. This is an example. We have the European Network for the Study of Cholangiocarcinoma and the International Cholangiocarcinoma Registry that during the last year we were able to put together a very complete registry database of patients. Primarily, we started from Europe, and now we have expanded in Latin America, certain centers in Asia, hopefully soon in Africa and United States. We were able to include more than 6,000 cases, and there are multiple studies already published or ongoing. So if anyone is interested to join this important collaborative study, please send me an email and we will provide you with all the information. So in conclusion, cholangiocarcinoma research is evolving fast, and this provides tremendous hope for patients and for the whole community. These are highly heterogeneous tumors, but cholangiocarcinoma is a unique cancer for personalized treatment, particularly because a high proportion of genetic alterations are potentially actionable. So it's very important to conduct the tumor molecular profile in tumor tissue at diagnosis. If there is no tumor tissue available, an alternative is to evaluate the tumor mutational profile by ctDNA, by circulating tumor DNA in blood. These are patients that must be managed by multidisciplinary teams. And as I indicated before, there are a number of clinical trials currently ongoing that I'm pretty sure that will provide positive results in the next future. I want to thank the different institutions that support our studies, and of course my team in San Sebastian, all of our national and international collaborators, and of course all of you for your attention. Thank you very much.
Thank you. Thank you. Thank you. That was definitely a very powerful and impactful presentation. So thank you very much. I do have some questions that have come through. So for anyone else, you can always send them privately to me. You can put them in the chat, or you can put them in the Q&A. And once again, if you have any questions, ask them now, because we will stop on time just so we remain respectful. So the first question had to do with a mechanism of risk factors. You highlighted some risk factors for cholangiocarcinoma, and you mentioned parasites and the association in Asia. Could you explain what is the mechanism of these risk factors and cholangiocarcinoma? How does it happen? And then are there specific regional factors, just like how you mentioned with the parasites?
Yeah, excellent. Excellent question. Yes, the Orpistorchis viverrini and the Clonorchis sinensis, these are liver flukes. These are present in certain lakes of Southeast Asia, particularly in certain regions of Thailand, Cambodia, and Vietnam. So these flukes actually are eaten by the snails of the lakes and rivers, and then these snails are eaten by the fishes of the lakes. There is a traditional plate in those areas that is basically is based on raw fish. So it's uncooked fish, and these flukes that are in the fish are taken by the individuals. Then they migrate through the biliary tree and stay for years, causing inflammation but not significant symptoms. And these over time might develop biliary tract cancer. So there is a high significant association between these liver flukes and cancer in those regions. For example, veterans from the war of Vietnam, from United States, when they went back to United States, a significant proportion of cases developed cholangiocarcinoma associated to liver flukes, for example. We don't have these flukes in theory in other countries, but it's quite endemic from those regions. But this is the mechanism of contamination and action.
Thank you. And I'll try and combine some questions. The next question was about aspirin and the PSC study you mentioned. So the question was, is that use of aspirin only specific for patients with PSC and cholangiocarcinoma, or does the risk of cholangiocarcinoma also decrease in patients who don't have PSC but are at risk for cholangio?
Yeah, that's a good question. The epidemiological studies that I show include all kinds of cholangiocarcinomas, not PSC related. There was an association with a lower risk of development. We don't know if it's through the anti-inflammatory effect or etc. of aspirin. But this is something that must be investigated prospectively. That was why in the UK they initiated the analysis of aspirin in individuals at high risk of cancer development, which are those with PSC that are under surveillance. So I think it's a good group to start to try to see the potential value of aspirin. I know this study is going to take at least 5 years. And it's including a large number of cases in the UK. So in the next future, we will know more about that. No?
All right. Then the next question was about the location of the cancer and the clinical outcome. And I think they mean like intrahepatic versus extra and perihilar. Is there a difference with outcome based on the location? Does it matter where the cancer is located and the outcome?
Well, that's a very good question. When we evaluated, the clinical response to surgery, to active palliative treatment, or best supportive care, we didn't see big differences, only between intrahepatic cholangiocarcinomas and perihilar and distal under best supportive care, but not under active palliative treatment or chemotherapy. We are now conducting a large international study to see how the presence of chronic liver disease impact on cholangiocarcinoma presentation and management and outcome compared to individuals with cholangiocarcinoma on healthy liver. We just presented this data in the ALE, in the Latin American Liver meeting in Peru. And basically, the results are very interesting because we found that individuals with chronic liver disease and cholangiocarcinoma usually they present better outcomes, better overall survival. Why? Because the cholangiocarcinoma is generally diagnosed in an earlier stage. So the patients under chronic liver disease, MASH, LD, PSC, cirrhosis, etc., although some of them has a protocolarized follow-up and surveillance and others not, the doctors, when there is a chronic liver disease like this, probably follow certain surveillance with biochemically imaging. And what we saw is that when this is the case, cholangiocarcinoma is identified earlier, and that's, they are more eligible to surgery and they show higher overall survival compared to sporadic cholangiocarcinomas that usually don't present symptoms in early stages and usually are detected in advanced stage. It's not being eligible mostly for surgery. This is data that we are planning to submit soon for publication.
Yeah, that's very interesting. And actually, it makes sense too.
Yeah.
The next question was about, which is an interesting question, the point you made about the CEA and the CA19-9. You mentioned CA19-9 is not expressed in about 10% of the population. And you said it's low in patients with local disease and it's higher in patients with metastatic disease.
Yes.
How does someone know that they don't have, that they're not able to express CA19-9, and what do you do?
Well, that's one of the big limitations of this biomarker, no? Because when it's low, you don't know if it's because the tumor is, is local, but as you can see with local levels, with local disease, the levels are low. You need to genotype the patients to identify if they have the mutation in the FUT3 fucosyl-transferase to really understand if they have the mutation, no? So it's very difficult, for early diagnostic purposes to evaluate the success of this biomarker. And when the disease is local, the levels are usually below the upper limit of normality, so it's not really good. But it's a biomarker that can provide information on the staging, no? So if a patient presents an elevation of CA19 and of CA, you should think that maybe this patient has dissemination. So you could probably ask for a positron emission tomography analysis and try to identify metastasis. No? Also, CA19-9, if it's elevated, as it was shown, is associated with prognosis, so with bad response to all kind of therapies. And is potentially used as a surrogate marker of disease response to treatments. So, for example, for Genthis, changes in CA19-9 when they were elevated before treatment were associated with response, with RECIST response.
Thank you. And I think just to tie that question in, is there certain regions that are known to not express it? Like certain populations?
Well, I'm not that aware. I think it's quite globally represented as far as I remember for some presentations, but I'm not really much aware on that.
Okay. Then the next question is about the stages. I think you did explain this though. When you had mentioned liver cancer, late stage, advanced stage in the African population, could you explain again why?
Yeah, that is something really interesting that we found. So, the Latin American population is very diverse, very mixed. So we decided to do this sub-analysis, trying to evaluate the presentation and outcomes. So we found that Caucasian individuals, although all the hospitals involved has a public system and is a system that everyone have access to the same treatment. So Caucasian, Hispanic, or African, we found that Caucasians show better performance, better overall survival. Why? No? Well, we tried to dissect this information, and we found, for example, Africans usually arrive in a very advanced stage. What we think is that most of these ethnic groups live not in the city centers where the big hospitals are, and they are probably in the surrounding areas where sometimes the primary care is collapsed. So probably they don't identify the symptoms that early, and also they are transmitted to the tertiary hospital late, late. So this is something that we just speculate, but makes sense. No, all the doctors believe that this is happening. On the other hand, we found that Hispanics, the stage of the disease was diagnosed more or less similar to the Caucasian. But we found the surprise that patients with advanced cholangiocarcinoma, the Hispanics, most of them, or a significant proportion, do not receive chemotherapy. So we don't know why. We think that we need to provide awareness and education of the benefit of chemo and a disseminated disease. And also we think that also socioeconomic aspects for people living probably far to the tertiary hospital to go every week for chemotherapy could be also an associated reason of the low adherence to the chemotherapy treatment, because these are usually conducted in 6 months. Every week you need to go to the hospital with some vacation period, but it demands an important family organization, economic support, and so on. So this is something that we want to address prospectively in the area.
I think now this is just my comment, not from the question. I think that you make a very important point about the late stage, advanced stage in the African population, because even the different cancers within the African continent as well, that's a very common, it's a common phrase. It's a common thing where people are coming in at a late stage of presentation, advanced disease. And I think the question you're asking is truly an important question. And I think what would be interesting, and it's something we can chat about on the side, and maybe anyone in the audience who's listening, is maybe even looking within like the African continent itself and within the African population in Latin America, and just kind of comparing those two different continents and seeing if it's the same. But I think you raise a very, 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 very important question that, needs further analysis. That's really good, that there's opportunity for us to compare populations within the African population in Africa and the African population outside the African continent, and even move beyond looking at that late stage. But then even, I think there's some questions about this, even looking at sort of the treatment responses. And then you had mentioned things about, the genetic mutations and things of that sort. But I think that's a really important, it's a really important point.
Yeah, we definitely are looking forward to involve more centers in Africa in the International Cholangiocarcinoma Registry. So we welcome everyone interested, and definitely I think we need to improve awareness and education on early symptoms, particularly in primary care and in the general population for early protection. Yeah,
absolutely. There's another question. I think these are tied. This is about the drugs, and once again, this question is about the responsiveness to the drugs. You mentioned targeted therapies and mutations, the DNA translocations, fusions, RNA fusions. Is this specific to certain populations? And I think the question is also going towards who are the participants in the study? Could you translate your population and the studies to other parts of the world?
No, I fully agree. And this is a very major point because most of these trials were conducted in the US and in Europe. For example, now we are doing a study in Latin America, trying to do a prospective analysis of ctDNA of patients with cholangiocarcinoma, trying to investigate the mutational profile and compare with other regions. Hopefully, we will be able to do in Africa and in Asia, there are some data. I think it's important. Some of these mutations, as I mentioned, are specific for certain subtypes of cholangiocarcinoma, some of them more intrahepatic, some more perihilar. So I think the risk factor, the pathogenesis, the origin and the target cell is very important in the mutational profile and in the characteristics of the tumor. For example, mutations in IDH are believed to occur in progenitor cells within the liver. So in the progenitor cells present in the canals of herring. So these kind of mutations, for example, promote, for example, the inhibition of the cell differentiation to hepatocytes, so inhibit HNF4 alpha, which is an important transcription factor for hepatocyte differentiation. So start the malignant transformation of the progenitor cell into a biliary phenotype, more biliary phenotype. These are sometimes associated to cirrhosis, to some chronic liver diseases, where are mutations in KRAS, in P53. These are usually occurring in large bile ducts, for example, in patients with PSC. So also the liver flukes, for example, are associated with mutations in KRAS and P53, which are mutations associated usually with a pro-inflammatory cancer phenotype. So definitely the mutational profile, we need to investigate more, have more detailed information on the clinical data of the sample, but there might be a significant association between the subtype, the molecular profile, the etiology, and the pathogenesis.
And I'll connect with you, on the side. If you'll give me information that I'm happy to share with everyone about how they can connect with you in terms of participating in some of those studies to make them, additionally global, like you're doing right now.
That would be wonderful. I mean, I can share my email. If you can say my email to everyone,
Yes.
I will be very pleased. And also, we have an international consensus of cholangiocarcinoma, where we have included multiple experts from all over the world. That is going to be published in Nature Reviews in the next weeks. It's a full detailed wrap-up of cholangiocarcinoma from biological, molecular, and clinical aspects involving multidisciplinary people. And also we involve patient associations. We did a Delphi panel with more than 300 experts worldwide, with important unmet needs and everything. So I really encourage all the people interested to read the manuscript.
Wonderful. We're going to take one last question because we only have 4 minutes. And this is a really good question as well. So the question is about jaundice. So elevated bilirubin, is this a prognostic factor in hilar cholangiocarcinoma?
Well, we in the univariate analysis and in the multivariate, jaundice was not identified, bilirubin was not identified as a prognostic marker. ALP level, I mean, CA19-9 level sometimes is associated with obstructive cholestasis with jaundice, but we found, including also bilirubin, alkaline phosphatase, CA19-9, all together in univariate and multivariate analysis, bilirubin was not an independent prognostic factor. Obviously, we need to control the obstructive cholestasis, so it's important to conduct stenting in order to provide a chemotherapy for patients with advanced disease, for example. No, obviously, you need to control that. But it's not considered an independent prognostic factor according to at least data from the registry.
Thank you. And I apologies to anyone else with questions. Just looking at time, we would have to conclude. And once again, just a big thank you to Dr. Jesus Banales on behalf of Massachusetts General Hospital Global Gastroenterology Program, the Division of Gastroenterology, and the Center for Global Health. Truly appreciate your time, your dedication. This has been a very fruitful and impactful educational program. So really appreciate your dedication. And on a personal note, thank you so much for your patience and just replying to all those millions of emails. I'm glad we could make it happen. To everyone else who's listening, this is a CME approved program. This has been recorded. We will try to upload this onto YouTube. It will be uploaded through the MGH side for all those who are internal. And the next program for November is pancreas. So November is Pancreas Cancer Awareness Month. And we have an amazing panel of speakers. We are going to be talking about building a pancreas center with our partners in India. So Dr. Shirin Shetty, who's at Kasturba Medical College in Manipal, India. And then our director, Dr. Yasmin Hernandez Barco. And then our chief of abdominal radiology, Dr. Avinash Kambadakone. And then hopefully we'll have a pediatric gastroenterologist who will also talk about pancreas disease in children. And so we'll have those that information out to you on our various social media platforms. So Dr. Banales, once again, I look forward to seeing you in Nigeria next year, I hope.
I hope so.
At AHBCC, so the African Hepatopancreatibiliary Cancer Consortium meeting, which is where we first met in person a few years ago. I think it was in Ghana as the first time years ago. Yeah, it was absolutely lovely. So hopefully I'll get to see you again in person next year in Abuja, Nigeria. To everyone who's on this call, it's 29 after. We stop in 1 minute. good morning, good afternoon, good evening, and a big, big thank you for your time, everyone. Feel free to contact me if you have any other questions. Take good care, everyone. See you later. Thank you. All right, take care. Thank you.
Bye.
All right.